Hi everyone. Um, Bob here. I saw this ECG case I found quite interesting, and I just felt it would be cool to share it with you lovely folks on the internet. So, you have a standard 12 lead ECG on your screen. I don't know how familiar you might be with ECG as a concept, but if you are familiar with it, you can see what's wrong at first glance, but it helps to always be systematic, you know. The concept or the idea is to make a diagnosis based on what you see on screen to help you catch heart conditions or heart problems and to posit management approaches that are beneficial for this particular patient. So, there isn't a question stem with it, just the ECG picture. So, I'm going to leave it on screen for a little bit. You can actually pause it just to try and compose the findings you see and see if you can come up with a reasonable diagnosis. Okay, so in summary, some of the findings for this particular ECG, as with analysis of any ECG, you have to start with the concept of whether the ECG is sinus or non-sinus. This ECG is non-sinus, right? Yes, we can see, sorry about that. We can see depolarizations. One second. Okay, we can see depolarization and atrial activity right here, but this doesn't count as P waves. This counts as flutter waves, right? The shape of this tells me it is that of a flutter wave. A standard P wave is biphasic, but it's almost distributed equally on both sides, while a flutter wave is more sloping or slanted in one direction. So either the upstroke is quick and the downstroke is slow, or the upstroke is slow and the downstroke is fast. So it gives you this sort of sloping image, but it is what we call a flutter wave. So that's what we have here. It's a non-sinus rhythm, right? So if it's non-sinus, that means we can't calculate the standard heart rate. We can't calculate the standard heart rate for this sort of ECG. We have to approach it by calculating the atrial rate versus the ventricular rate, or the atrial activity versus the ventricular activity, right? Oh, by the way, it's irregular, right? Because we can see the gaps between the RR intervals. Those gaps are not constant. They're shifting and changing in duration. So it's irregular. It's something you should always remember. Then you have to calculate that, like I said, the heart rates. We're going to calculate the atrial rate for this particular case. If you remember, the formula for calculating atrial rate is 300 over the number of waves you see in, say, one big box, right? And usually we extrapolate that to be 300 over the number of boxes you between RR interval. So in this case, it's going to be 300 over 1. So the atrial rate is 300, right? 300 per minute. We're going to analyze the axis. The heart axis, you can notice then that the heart axis, you analyze it by monitoring or looking at the lead 1, lead 2, lead 3, AVF, AVL, right? Those are the things that allow you to get a picture of the heart axis. So we have a positive QRS complex in lead 1, right? Then a positive QRS complex in lead 2, and a mostly negative QRS complex in lead 3. So this tells me that this is a normal axis for the heart. It lies within the framework that allows, it lies between the -30 to +60 range, right? So that's a normal axis of the heart. All right. After that, we have to try to locate the PR interval. But remember, I mentioned there is no P wave, so we can't have a PR interval. So PR interval is absent. Same as P, we can't find P because there is no P wave, P duration, we can't find it. The best we can do is compare QRS complex. So the duration of the QRS complex standard is 3 small boxes or less. In this case, we can see it's neatly 3 small boxes. Any one QRS complex you evaluate will be 3 small boxes here, which is 0.04 times 3, which is 120 millisecond or 0.12 seconds. So very neat, very easy. Narrowed QRS complex or normal QRS complex, as the case may be. There is no T wave, so we can't check the QT segment. We can't search for ST elevation because there is no T wave. Yeah, so in summary, some of the findings we see are no P waves, flutter waves instead, normal cardiac axis, atrial depolarization rate of 300 per minute, narrow QRS complex. Yeah, there's our classic findings we see in something called atrial flutter. You can actually check to confirm if, say, there is a concept of a bundle branch block. No bundle branch block. Okay. William, you know how to check for the bundle branch block. We use William for left bundle branch block, and we use Marrow. I will make a video around that soon, but none to be identified in this particular ECG. So yeah, so we can see a summary of the findings. No P wave, non-sinus, regular, normal cardiac axis, is positive in 1, 2, and AVL, but negative in AVF and lead 3. Atrial depolarization rate of 300 per second, ventricular depolarization rate ranging from 75 to 150, right? So in some instances, we see 2 big boxes between the ventricular complexes, so it is 300 divided by 2, which is 150, and in some instances we see 4 big boxes in between the ventricular complexes, which is 75. So the ventricular depolarization rate ranges from 75 to 150. The conduction rate then is 2:1 to 4:1. That's a range, right? Meaning atrial rate of 300 over 150 to a range of 300 over 75. If you work that out, it will give you a ratio of 2:1, ranging to 4:1. There is no PR interval because we don't have any P waves. We have narrow QRS complex because we've checked it less than 3 small boxes or less, so 120 milliseconds. We have sawtooth waves on lead 2, lead 3, AVF. So sawtooth waves, you can see they resemble the tooth of a saw, right? These are classic findings in atrial flutter. No T waves, no ST elevation, and then a positive flutter wave in lead V1. All right. So full ECG findings: atrial flutter with a variable conduction rate ranging from 2:1 to 4:1. with findings suggestive of an anti-clockwise re-entry circuit. Yeah. And then what do we understand by atrial flutter? It is a complex tachycardia. We know what a tachycardia is when the heart beats rapidly or higher than normal, formed by the existence of a re-entry pathway in the heart. Very specifically is existence of a re-entry pathway in the atrium. So impulses almost never get conducted down into the ventricle and circulate within the atrium, causing repeated depolarization until some waves or some depolarization waves travel down into the AV node and are conducted. That's why we have a conduction ratio. You notice we said a conduction rate of 2:1 to 4:1, meaning for this particular patient, every second, not every second, but every third depolarization is conducted, and every fifth, it's a range from every third to every fifth depolarization rate from the atrium being conducted. So we could have typical atrial flutter, which could be clockwise or counterclockwise, but we could also have atypical atrial flutter. What are the typical ECG findings in atrial flutter? We have high atrial rate, right? Greater than 200. Remember in our question, our patient had atrial rate of 300. Ventricular rate is variable. Notice as our patient had a 75 beats per minute rate to 150 beats per minute rate, so very variable. Narrow QRS complex. There is no problem in the QRS in the ventricle itself, so the QRS complex is expected to be narrow. Flutter wave in lead 2, lead 3 AVF, right? If flutter wave in these leads are positive, this is clockwise. It's a clockwise circuit. If flutter waves are negative, then it is a counterclockwise circuit, and we'll see flutter waves in V1, right? Sorry, if negative in these leads, it is counterclockwise. All right. Again, negative flutter waves in leads 2, 3 AVF, and positive flutter wave in V1 is counterclockwise, while positive flutter wave in lead 2, 3, and AVF, and negative flutter wave in V1 is clockwise. So what does a positive flutter wave mean versus a negative flutter wave, right? This is what we call a positive flutter wave, where the upstroke, the speed of the initial upstroke is slow, and then a rapid downstroke. So it takes a longer time to reach its peak than it takes to get to the bottom. That's a positive flutter wave. And if you notice positive flutter wave on leads 2, 3 AVF, then this is a clockwise circuit, right? And then a negative flutter wave is when the upstroke is very quickly, it takes a very rapid period of time to reach its peak, but then a very slow period of time for it to a very short period of time for it to descend to its lowest point. This is what we call a negative flutter wave, and when we see it in leads 2, 3, and AVF, it is indicative of a counterclockwise circuit. So how do we calculate ventricular conduction rate? I explained it briefly in passing, but for these patients, we just simply take a ratio of the atrial rate to the ventricular rate. In this patient, it's 300, and our ventricular rate ranges from 75 to 150. So we can actually develop a range for the conduction rate, right? So it's going to be 300 over 75, 4:1, but it can also be 300 over 150, which is 2:1. So the conduction rate ranges from 2:1 to 4:1. Thank you.